Okay, welcome everyone. My name is Adnan Hyder. I'm the Senior Associate Dean for Research and Professor of Global Health here at the Milken Institute School of Public Health at George Washington University in Washington, D.C., USA. A warm welcome to all of you joining. I know many of you are joining from this country, but many of you are also joining from other countries, and I hope that everyone is healthy and safe, particularly during these challenging times around the world. I'm so excited to continue to moderate and present this series on ethics in COVID. This particular webinar is going to focus on research ethics, but on behalf of the Milken Institute School of Public Health, the Office of Research Excellence, which I direct, and the Bioethics Interest Group here at the School of Public Health, we are truly excited to continue to sponsor this webinar series to explore ethical issues around some of the important issues, challenges, domains of interest, and topics that are emerging, particularly in the times of coronavirus. We've been doing these webinars now for several weeks, and we are gratified by the increasing interest, not only in this country, but around the world. And so pleased that many colleagues from Asia and Africa as well are going to join us today, including those from Europe and North America. I'm really excited at the webinar today because it's going to focus on something that is very close to the conduct and business of the School of Public Health, which is research ethics. Research ethics, of course, is a very large topic, a very large domain, but I have two amazing panelists who are going to help us explore what research ethics means during the time of COVID-19, and of course, some of the nuances that we would like to talk about. The way this webinar is going to work is I'm going to request each of our panelists to provide an opening discussion for about 10 minutes each. They may be using a few slides to help them. And at the end of that, I'm going to throw open the discussion section. Please, as you hear our amazing panelists speak, put your reflections, put your comments on the chat board. I have colleagues monitoring the chat board, and I will turn my attention to your comments and questions and direct them to our panelists at the end of their presentations. I will also take the opportunity to reflect on various things as we go along, in particular to demonstrate the value that ethics brings, the lens of ethics brings to a discussion of COVID-19 issues. I also want to give a shout out to any of our students who might be in the audience. Please remember that if you have any PE forms, make sure that my colleagues Michelle and or Hina Sheikh have access to them and can sign for you. Welcome again to those of you. I know the population seems to be doubling every second here. Welcome to those of you who've joined in the past few minutes. I want to introduce our first panelist for today. I'm so delighted to have my colleague Deborah Paxton with us. Deb is the director of the Office of Human Research here at George Washington University. She leads the Institutional Review Board and the Office of Human Subjects Research. She has nearly 20 years of experience in research, both as a researcher, as a research integrity officer, as an IRB director at multiple institutions, and has her own experience of biomedical and behavioral research. In addition, I know Deb is a valuable consultant and colleague of many IRB directors and colleagues in research integrity around this country and around the globe. So Deb, I'm so happy that you could spare the time to join with us and looking forward to hearing your thoughts on research during COVID-19. Over to you.
Okay, great. Thank you very much for that lovely introduction. Full disclosure, I am recycling a talk I gave a couple months ago as COVID was ramping up. At another panel that I participated in. These issues remain current, and they're meant to broadly encompass some of the unique issues facing researchers, and address some ways to consider them and maybe address the challenges. Next slide, please. So there are, in my estimation, kind of four broad areas of challenges for research occurring during the COVID pandemic. The first is a sense of urgency, rightfully so, towards treatments and cures, and a diversion of resources to research designed to ameliorate or shorten the pandemic. The second is unique research opportunities posed by the COVID pandemic, right? As I think we've all heard the phrase, these are unprecedented times, and researchers love to study unprecedented times. It offers a lot of opportunities for unique insight and unique research. The third challenge is maintenance of ongoing research, right? In a lockdown status or quarantine concerns. How can you maintain research that started or was planned prior to the pandemic? And sort of related to that is the fourth issue, which is reconfiguring risk versus benefit, right? So really, in my world, in human subject protection, one of the most basic considerations that needs to be made is a risk-benefit ratio, right? The risks of research need to be adequately balanced by expected benefits. And COVID, the pandemic, throws in some new and unique and unclear and scary risks. And so it's made us, we need to reconfigure our usual assessments of risk and benefit of research. I'm going to talk briefly about each of these issues. Next slide, please. Okay, acceleration towards a solution, right? So there's a high sense of urgency around research, and I'm sure Julia, as well as I am, in IRBs, we're getting a lot of very urgent requests. One of the tricky parts about this is that in the U.S., a lot of the treatments that might help COVID patients remain experimental in nature, right? And the US government, the FDA, requires IRB involvement to assess experimental treatments, right? It's called expanded use, also compassionate use. There's different terms for it. So that has been very challenging, and some things to keep in mind are making sure that you as researchers remember the difference between research and treatment, that when expanded use is done, it is a treatment, it is not research. There are limitations to how the data that are generated and collected during expanded use treatment can be used and presented. There are flexibilities. So the U.S. government has, this is a little outside of my slides, and I probably get into it later on. But so the U.S. government has, in the months since the pandemic, offered some flexibilities in terms of expanded use and options for IRB oversight of expanded use. The best example I can give is the use of I'm not remembering the term now, of blood from survivors, right? And so the government has allowed a very simplified process for relying on one IRB to serve as the IRB of record for expanded use across the U.S. So there is response from regulators occurring. I'll talk about that in a little bit in future slides. Some other things that are happening and need to happen at institutions, at research institutions, is prioritization of research, right? So that's one way that GW as an institution is managing this. We have a huge uptick in research requests, right, in the IRB and at the institution as a whole. And we need to appropriately prioritize research, right? Keeping in mind the benefit of the research, the level of in-person interaction that the research entails. And this prioritization, we also need to keep in mind the limited data that exists right now. So what I mean by that is at GW, we have a lot of research requests to use data and specimens from COVID patients. And there's a limited number of specimens that we have. And so we're asking for prioritization at the departmental level of research requests from researchers within each department, because we don't want to be doing that sort of prioritization at an organizational level. It's better for the department leaders who work more closely with their researchers to be identifying priorities for the department, identifying opportunities for collaboration between researchers, et cetera. Okay, I'm going to pick it up because I'm running out of time. And so another thing that we can do is incrementation. So acceleration towards a solution does not mean that we eschew any review criteria or any ethical concerns. A way to address that, because there are a lot of question marks in a pandemic with unclear information and a lot of question marks about the future, is I recommend smaller is better, right? Start with what you know, design your studies incrementally. So you can start with what you know, and as you generate more information, communicate with your IRB and your regulators to move forward. Next slide, please. Similar statements here for the unique research opportunities, right? There's a sense of urgency. There's a need to remember appropriate review requirements, prioritize what you're doing. In the past with big data, there's been a trend for, trying to collect as much data as possible and making as broad of research designs as possible. This might not be the time or place to do that, right? Because the reviews of that type of research tends to be much more in-depth and can take longer, and there are more ethical considerations for that type of research. So I recommend here that A, you focus on studies that have a direct demonstrated benefit, and B, that you're being very parsimonious in your design and have targeted research questions. Next slide, please. Similarly, maintenance of ongoing research. So the challenges here are reconfiguring the risk versus benefit ratio and working within physical and safety constraints. What that means for us, there's kind of two parts to it. The first is a lot of modifications being submitted to the IRB for ongoing studies that used to involve in-person interactions that can be switched to be remote. And there is, sometimes that's not as simple as you would think, right? Depending on the study. There are different privacy and confidentiality concerns that are associated with moving to a remote data collection platform. Global or international research, you need to be aware of connectivity and internet privacy regulations or laws in the foreign countries. So it's not quite as simple as you might like, though it can be taken in context of the research itself. So, for an example, a study that involves HIV positive participants, we are going to want to be a lot more careful about what the data security and confidentiality protections of that remote data collection are. Okay, next slide, please. Okay, and reconfiguring risk versus benefit. I think I've touched on this. Something else to consider that's not necessarily in the human subjects realm, but absolutely is in the research ethics realm, is the risks to research personnel. I know that a big part of IBC, or a part of IBC, Institutional Biosafety Committee review, has to do with the welfare of lab and research personnel when working with pathogens. So if your institution or your research involves working with the COVID virus or samples from COVID infected patients, be aware of that additional level of concern for research personnel. Next slide. And finally, the regulators are working with us, and they too are trying to find flexibilities and ways to minimize unnecessary regulatory burden. A good example, as I've given, is a streamlined ability to rely on other institutions. Also, researchers have been in communication with sponsors to maybe reconfigure deliverables of awards made before COVID for research that needs to be modified. in response to COVID. And so, the regulators are working with researchers, and there's a lot of communication and collaboration with the IRB as well and the IBC. So my best advice for both of those, right, is to communicate more rather than less, right? Be an advocate for your research, be clear about what you're dealing with, and suggest a solution or a way you'd like to move. I find that I get a lot of emails from people that include what I call a problem statement and no other kind of suggestions, right? It's just oh God, what do I do? It's a lot easier for us to help you when you say, oh God, what do I do? This is what I think I should do. And then we can say, yep, add this or take that away. And I am done. that was a whirlwind.
Thank you very much, Deb. Truly
Sure.
appreciate the fact that you could cover particularly what you call the 4 important challenges in terms of accelerating research, identifying the unique aspects, maintaining it, and then reconfiguring the risk-benefit ratio. Thank you very much for those, and we'll come back to that. Folks, Michelle, could I just ask you to ensure that Hina can look at the waiting room? Could you go ahead and check the waiting room and admit a few more people? Folks, for those of you who are listening to this, we do lock the meeting room to ensure that we don't get, these days there are people Zoom bombing and things like that. If Michelle, if you are switching the slides and you need some assistance with that, could you ensure that Hina and or Paul could monitor the waiting room and allow a few other IRB members from other institutions to join the meeting? Thank you very much. I'm now very excited to request our second speaker to discuss research ethics in the times of COVID, Julia Slutzman. Julia is the Director of Research Regulatory Affairs at Children's National Medical Center and an Assistant Professor in the Department of Pediatrics at GW, School of Medicine and Health Sciences. Julia has actually previously been at the NIH working as a bioethicist in multiple roles, including in human subjects protection, including on the National Children's Study. So she's really had tremendous expertise, particularly with pediatric research ethics and child research ethics as well. So I'm going to hand over to you, Julia, to make your opening comments. Please go ahead. Welcome.
Thank you so much. Thank you very much, Adnan, for that kind introduction and for the opportunity to be a part of the conversation today. If I could ask for the next slide. I'll just touch on a couple of points. Deb did a wonderful job in really laying out the new regulatory landscape that IRBs and human research protections programs are navigating, both with changes in allowable research and in trying to manage new research requests. And so I will very briefly cover some areas of challenge and questions that have come up in the experience at our institution. And by way of context, I'll say that I'm speaking on behalf of Children's National Hospital, which is a pediatric hospital. And so the majority of our research focuses on children. And so I'll be focusing on some issues that are specific to pediatric research as well. So to take a step back and to talk about where we were a couple of months ago when the pandemic began, and our institution, like others, needed to make some difficult decisions about reducing research to maintain the safety of subjects and staff. And so we very quickly worked internally and with colleagues to develop a plan for in a fair and equitable way, thinking about which in-person research activities could continue because many of the clinical activities in the hospital were radically reduced, and which couldn't. And the way that we approached that was to identify different tiers of research based on the level of direct benefit to participants presented in the research, and also taking into account the risks of taking away an intervention if the research contained one from subjects. And so we established these tiers of research, and then we developed some phases of research activity for our institution, allowing us to titrate up and down, if you will, the amount of allowable in-person visits by type of benefit provided by the study, and also by community and contextual factors. So availability of PPE, level of community spread, availability of clinical space, and safe social distancing practices in the hospital. And we worked across different components of the hospital to do that. So it was a I think an important example of the importance of communicating clearly across both clinical and research parts of an institution. We based our approach on a scheme developed by Hopkins, and in a way, I think it was a little bit easier for us to implement this because in the U.S., the HHS regulations that help IRBs determine risk to children actually speak about direct benefit versus direct benefit, which isn't the case in the risk definition on the adult side. So it was a little bit easier for us in the context of some studies to identify those which had direct benefit, and then to be thinking more specifically about the level of direct benefit. Something about this approach that I think was an area of opportunity in education was we were really asking investigators to make these determinations about whether the research had great potential for direct benefit, moderate potential for direct benefit, or no potential for direct benefit. And for some studies, the IRB had made this determination based on the regulation, and in others, investigators really had to think hard about this and grapple with this. And so something that was interesting for us was to see cases where, for example, in phase 1 studies or studies where there really isn't necessarily potential for direct benefit, we had a very active discussions with investigators thinking hard about what that means and why their particular study may or may not have direct benefit, even though many investigators are in certain fields are very, very used to seeing their work is really integrated into clinical care. So I think this is a tension that always exists, and it was a way to have that education and thinking together in a shared way with investigators and in real time. Categorizing studies into potential for direct benefit and high direct benefit also became challenging in certain studies with multiple arms, where the risks to bringing in a healthy patient or somebody not an intervention arm may be different than bringing in somebody who's on an intervention. And if the study is randomized, it's difficult to know. So we had a lot of interesting conversations with investigators thinking hard about how we think about benefit. Deb has already touched on a lot of operational challenges, and I won't say too much about this, but I will simply say that to maintain regulatory compliance, even in some opportunities of flexibility, we also had to move quickly with making changes to our IRB submission system and really trying to communicate them. So I think one of the lessons in this, when we were in this earlier phase of reducing allowable research, was to communicate clearly and often, which I think is known generally in public health. It was very important to us. And the next slide, please. Thank you. So where are we now? So we reduced very significantly the research that was able to proceed in children's, basically to in-person activities for studies with direct benefit, or where withdrawal from the research or pausing the research would bring harm to patients if they need safety labs or other kinds of safety monitoring. And then we allowed other studies to maintain activities that they could be done in a virtual manner by telephone, online. And we also worked very closely with investigators to find mechanisms for electronic consent, which we didn't have up and ready to go. So really identified an area where we knew we needed to develop, and really to be creative and to bring that capacity on board as quickly as possible. Right now, we're thinking about how to ramp up the research, and finding that it's actually a little bit more difficult in some ways than thinking about how to reduce. And that's in part because we're coordinating very closely with the clinical side of the house. So at our institution, much of the research takes place in clinical spaces, much of it in ambulatory care spaces, and Children's has many regional locations which differ in size, the communities they serve, availability of parking. And so some of the safety practices, social distancing, ability to have PPE, ability to have sufficient room cleaning, which and in a situation, I think, like many clinical places where there's more time between patients, you wouldn't have 20 people in a waiting room together. It makes it much more difficult to bring back research, which might add to the duration of clinical visits and might also include more individuals interacting with patients aside from those needed for clinical care. So we've been thinking about slightly expanding some research to involve in-person activities for studies without direct benefit that have a minimal additional time and don't include any additional patient interactions. Again, very, very small increments, and the importance of communicating these and assigning equitably which studies can continue is important. And we've been trying to minimize case-by-case approaches and trying to really make these distinctions based on clinical capacity and safety and type of study. Something that we're also considering is, after working remotely and having our IRB meetings take place remotely, is whether we want to go back to having IRBs meet in person. And something we've noticed in the past is we typically at our meetings have community members and others who aren't on site at our institution, or maybe clinicians at different sites, and who've been calling in historically. And there's been a little bit of equalization of the playing field to have everyone being able to see each other remotely and not have some people on the phone and in person. And I think these have cut different ways and are different. We have 3 panels of the committee at Children's. But something that we found among some of the panels is it's actually been a nice opportunity to equalize participation of our colleagues who are typically over the phone and versus those in person, and also an opportunity for us to consider reaching out more broadly for outside members and expertise, since we're all remote. So it's an interesting opportunity to consider what the value is and isn't of the traditional in-person IRB meetings, at least in our institution. And the final slide, please. Thank you. So more broadly, the kinds of questions that we're thinking about, seeing the kinds of additional research requests that we're getting and thinking about potential ones. One is, how do we fairly allow studies to access the limited cohort of our COVID-19 pediatric patients? So Deb mentioned earlier, there's always a tension in how to deal with specimens, since they're not a non-renewable resource, and also to allow access to subjects, and particularly in pediatrics, where there's fewer children nationally in the US and internationally who've been affected by COVID, and also now the subgroup of children that have multi-system inflammatory disease, and children happens to have a fairly large sample of these. How do we prioritize studies to allow fair burden to participants and fair opportunity to participate in research, but also consider that many of these families are going through very difficult times, might come from groups that are disenfranchised, and really be sensitive and fair in both allowing kids to participate in research and also being protective of these participants. Another way that plays out in the pediatric population too is that the convalescent plasma research that Deb referred to. So in the US, there's a large national study of convalescent plasma, and that study enrolls individuals aged 18 and older, so it doesn't enroll kids. And for kids to receive convalescent plasma, there needs to be an expanded use request to the Food and Drug Administration. And so that's, even though that's happening on an accelerated basis, it's still burdensome and can cause delay. And so it's sort of causing questions about equity. Should there be a national effort to allow access to convalescent plasma more easily for kids? Another question that's come up for us is, for some of the interventions that might be tried, these might be interventions that have been used for other indications, but in adults. And so for studies of the pediatric institution, we might be looking at intervention that's not only first in COVID, but also first in children. And how do we think about risk and benefit and communicating that in a context where the epidemiology has evolved, particularly in the extent to which COVID affects children, where I think that picture has really changed as time goes on, and there's more information, even more so than for adults. So again, a particular challenge. Another consideration that we've been thinking about is that there are a number of studies that are looking at interventions for clinicians who interact with patients on the front lines for prevention of COVID, potentially for vaccines. And so how do we allow our staff to have those opportunities, and also allowing for staff to feel comfortable saying no? So this is unique to COVID. This is always a tension with research with staff, but something that is coming up specifically in studies that we're seeing. And finally, another question that we've been thinking about, and I'm very curious to hear about how others have been thinking about this, is we have multiple studies for other infectious diseases, upper respiratory diseases, for example, common in kids. And so those are studies that have been completed. It might be samples from children with flu from a year or two ago. And now there's interest in perhaps looking at those samples for use as controls or in other ways to help advance the effort for COVID research. And how would we consider whether it's even possible to repurpose those samples when consent may have been completed if there's interest in identifiable samples. So different iterations, I think, of kinds of research, again, not unique to COVID, but I think important now in the kinds of study designs that we're seeing and that we'll see. And I look forward to hearing others' thoughts and how others have been thinking about this kind of research. Thank you.
Well, thank you very much, Julia. Really appreciate your bringing both the research reduction that happened at the start of COVID and continued for several months, and then later on now as we are getting into research reopening processes. And thank you for highlighting those, and thank you to both of you for giving us the opportunity to hear your opening reflections. We have over 80 people now in the discussion. Please put up your comments or questions or reflections if you have any for our panelists to respond. I've already noted a few. And one of the things, Deb, that you mentioned that becomes really important is obviously many people think about protecting human subjects, but what about protecting the researchers in the context of a pandemic, in the context particularly of what I might call a very, very infectious virus? What do we approach about researcher protection? How is it okay for researchers to say, I'm not going to be doing any research at this time, and I'd rather be in my office just writing my papers or at home doing my data analysis? Any perspectives from an IRB viewpoint or from your experience, Deb?
Absolutely. And so first, it's always okay for people to make choices for themselves to keep themselves safe and comfortable, right? And my concern would be someone who is so eager to perform research that they might overlook some safety considerations or their own personal welfare. So it's not uncommon for an IRB to run up against human subjects welfare versus researcher welfare, right? There are researchers who put themselves in physical danger often for the sake of research. And I remain firm about appropriate boundaries and mission. And the role of an IRB is to protect human subjects, right? Not necessarily researchers. And so it's important for an IRB to alert departments and organizations if they feel that there is a concern or a health risk for the research personnel. But it's not, the IRB is not the appropriate body for those concerns to be addressed, if that makes sense.
I think that's a very important point, and what I hear you saying is it's not that we aren't concerned about it, that individuals should not have the prerogative and the autonomy to decide on it, but there might be different bodies in an institution who look after that in particular, right?
Yes, and that mission creep is a thing for IRBs that is concerning. And what that means is that it is very tempting for institutions to kind of shoehorn a lot of regulatory oversight into IRBs, and that obfuscates our mission, that gets in the way, and sometimes directly contradicts or conflicts with the role of the IRB, which is protection of human subjects.
Great, thank you very much, Deb, and I hope that those of us who are listening here, if you have further questions on this, please put them on the chat board, or even if you disagree with us or our panelists, let's have a debate about that. Because this notion of mission creep, I do want to come back to that a little bit later in our discussion. But Julia, one of the main priorities is to look after human subjects research, as Deb is reminding us. And in the times of a pandemic, there is added stress, right? So there's not just the usual concerns, but a lot, particularly of mental health worries. There are reports of people feeling anxious and depressed, and even reports of increase in things like suicides. So what do you think from your perspective, especially in view of the population like adolescents and the younger people that you deal with? Do you have any thoughts about that, any reflections, any experiences to share?
So that's a great question. I think that you know, that's a question that transcends research, but and you know, in general, there's a lot of hesitancy in people being outside and coming to clinical spaces, which are seen as particularly, you know, those of higher exposure. Although I think in some ways now, with appropriate PPE and social distancing, you know, that may be more of a risk perception than in actuality. Because in the pediatric context, there's always this notion of additional protections, and when they're necessary, I think it's always important to think about if there's an assent process, and this was certainly the case for older adolescent participants, what's being communicated. And we haven't required, and I haven't seen many institutions do this, add information about COVID to consents at this time. And something that's interesting to consider is, when in the US regulations, minimal risk, for instance, is defined, one of the touch points for minimal risk is activities of daily living. And so at some point, as this continues, whatever the level of COVID community spread will be, that might be an activity of daily living. It just might be the same risk of going and getting a well checkup just because it might become endemic. So I think it's interesting to see how it evolves and how we need to characterize that risk. The other thing I'll add is I think in some studies, especially studies where we think that some of the research questions might be distressing, might be concerning, there's sort of a common practice of asking about acceptability, of asking, was it difficult for you to participate and to do this? And so I think it might be interesting to consider, do we want to ask these kinds of questions for participants in research right now? Is there anything about this research context that changes the street? So I think that's an interesting area of study and thinking, but I think open communications about what it means to not only be conducting research, but to be participating in it right now is really important and part of a ongoing communications process.
And I would like to add to that part of what we're seeing at GW is COVID testing, right? So parts of research will involve a test for if an individual is COVID positive, and we are asking researchers to be very careful about the information that they give about that testing and how they present the results and what sort of resources they provide with the results, and also making sure to note whether or not, as per usual in research that involves testing, provide information about the diagnostic level of the test. Is it a diagnostic test or not? And how to interpret the results.
No, I think that is very, very important. And Julie, as you indicated, we have to recognize the additional usual stress in these times on people when they're staying at home, have to wear masks when they go out, have to maintain social distancing. So I think that becomes really important for us. I want to segue into a conversation about inclusion of vulnerable populations in, for example, COVID research, right? So both of you are very familiar with the fact that, for example, many research is done on limited types of populations and then generalized. The results are generalized to other folks. The classic case of course, gender, where a lot of studies were done on men traditionally, and then the results were generalized to females. But I think in this case, we've seen, at least in the US, a whole disparity argument has come into play with COVID-19 deaths disproportionately affecting vulnerable populations. And then the question is, should those vulnerable populations be involved in the development of solutions and new testing measures and new vaccines and new treatments for COVID-19? So Deb, any thoughts around the inclusion of these vulnerable populations to help with COVID?
That is a great question. And I've not necessarily seen plans for the involvement of those populations in development of solutions. I mean, it is a part of, clinical and translational research or community-based research, participatory research. But mostly what I've seen thus far is sponsor-led efforts at identifying cures and treatments. And when the sponsor is the NIH or a U.S. federal agency, there are requirements for diversity of representation, but not necessarily with a private sponsor, and certainly not plans for involvement of the community for further information in terms of enacting or sharing or disseminating or assessing the experiences of these populations. And I think that that's very important.